Bismillah ar-Rahman ar-Rahim. I would like to welcome you again in this new meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings in our usual time, Wednesday, 9 p.m. as usual. We are in this lecture with one of lectures targeting women in nephrology and this specific aspect of nephrology. And when we speak about this or think about this branch of obstetric nephrology, which is an ongoing branch nowadays, we are to go to Professor Rasha Samir to ask her to give us her expertise in this field. Our speaker today is Dr. Rasha Samir, Associate Professor of Nephrology and Medicine, Mansoura University. She is the ISN trainee in obstetric nephrology. And Dr. Rasha is the one of the group who started this specialty in Egypt by making a specific working group and making a specific clinic in Mansoura University targeting obstetric nephrology and care of women with kidney disease, pre and postpartum. Our topic today, as we usually speak about this or think about this topic, we are thinking about how to deal with this lady in pregnancy having a kidney disease and how to adjust medications, if any, and what are the expected complications and how to deal with these complications. But we are this lecture to hear from Dr. Rasha about how to care with pregnant female with kidney disease after labor, how to deal with obstetric conditions, and how to continue our care that started in pregnancy, in her partum period, in the postpartum period, and will give us a general idea about most of the diseases in nephrology. And we are expecting a very interesting lecture and very to the point and very practical lecture targeting this field. I would like to thank and welcome Dr. Mu'tasim Al-Sayed, our coordinator today, and for this work and all of his work regarding CME chapter meetings. And welcome all the professors attending, Professor Ayman Al-Rifai, President-elect, Professor Hisham Al-Sayed, Vice President of ESNT, Professor Said Khamis, and we are, I can see more and more audiences and more professors joining, so we are expecting a very hot discussion and very fruitful, to the point discussion after the lecture. So I will leave the floor to Professor Rasha to start, and welcome you back again with the discussion. So please, Professor Rasha, start.
Okay, thank you, Dr. Yasser. First of all, I'd like to thank the Egyptian Society of Nephrology and Transplantation and you, Professor Yasser, for the kind invitation and for your great efforts in the ACMT CME chapter. In this context, I would always express my gratitude to our dearest Professor Hussein Shaisha, to whom I owe my career path. And also would like to acknowledge the faculty board of ISNT Train the Trainer program in pregnancy and kidney and obstetric nephrology for revising the content, and special thanks to Professor Valerie for her input into the topic. As you just said, we are always concerned about pregnancy and dealing or caring about pregnant women with kidney disease. But the story is that when pregnancy ends, the story does not end. A new story begins with now two souls, a mother and a baby. The postnatal period is defined in terms of obstetric as a period beginning immediately after the birth of the baby, lasting for up to 6 weeks, around 42 days after birth. But in terms of kidney disease, we think that this postnatal period should be more broader and should extend longer, because there are long-term complications for the mother and long-term complications for the baby who's almost born as premature baby or small for gestational age on the long term. So the postnatal period in a woman who have a kidney disease is thought to be a very special period, is thought to be more lengthy than that known in the general population. So this will be my timeline. I will classify the talk into early postpartum period or early postpartum follow-up, short to moderate term follow-up, and long-term follow-up. So for the early postpartum follow-up, if we have a woman who has just delivered in January 1, the early postpartum follow-up reflects the first 24 hours after birth. And then short to moderate term from the second day to 6 months postpartum, and the long-term postpartum follow-up extends more than 6 months. And indeed, when we mention women with kidney disease, we have heterogeneous populations. We have women who have early CKD, those with late CKD, transplant recipient and donors. We have those on dialysis and women who have hypertensive disorders of pregnancy or episodes of pregnancy-related AKI. So having a heterogeneous spectrum and heterogeneous populations, very little data, this will make a great challenge to the talk. So starting by the early postpartum follow-up, I mean here the first 24 hour, and the first 24 hour can be further classified into the first few hours, and the subsequent hours till the time of discharge, and on discharge, what advice should we deliver to the women? Trigger the first few hours until the time of discharge. This will be heterogeneous among different settings and countries because actually, as it's seen in this map, the coverage and quality lag behind the global targets of hospital admission for a woman who just delivered. So we can say this ranges between a few hours in some countries to more than 5 days, and this will reflect that change in the practice. So for the first few hours, special care should be given for the mother to look at the vital signs, amount of vaginal bleeding, urine output, and encourage initiation of breastfeeding. As well for the baby to ensure adequate breathing, there is no hypothermia, and good eye care. So for the assessment of maternal well-being, we have to ensure that the women have a normal blood pressure, normal pulse. The uterus is hard, not soft. There is just little bleeding, no pallor. There are no perineal problems and no fever. Because in this period or in this critical time, having a postpartum infection, postpartum hemorrhage, or postpartum eclampsia all can contribute to postpartum acute kidney injury, which represents a greater proportion of women presenting with pregnancy-related AKI. The postpartum hemorrhage, which can be either primary due to uterine atony, acute uterine inversion, trauma, or clotting defects, or secondary to puerperal sepsis or retained placental products, should be carefully monitored to early pick the diagnosis of pregnancy-related AKI with urine output and serum creatinine. So in the first few hours, the initiation of breastfeeding should be encouraged. Breastfeeding is not contraindicated and should not be discouraged either in patients with CKD or transplant. Women with early CKD stages 1 to 3A, may breastfeed successfully. And women with advanced CKD may breastfeed if both the mother and the baby are stable. In terms of transplantation, women with kidney transplant can produce immunocompetent milk. And for dialysis, breastfeeding is not generally recommended because it is thought it will lead to more maternal exhaustion and because ultrafiltration may lead to hypovolemia and suppress the amount of breast milk. However, it has been found safer when mother breastfed after dialysis than before dialysis. This study showed that women on hemodialysis had significantly higher levels of creatinine, urea, and uric acid in pre-hemodialysis breast milk than in post-hemodialysis milk, but this is not sufficient to advise breastfeeding in women on hemodialysis. As it's just said, aggressive ultrafiltration is thought to reduce milk supply. Breastfeeding and mother's milk is tailored to the nutritional needs of her specific infants and thus remains the best option, particularly for compromised preterm infants. It confers a number of maternal advantages in terms of prevention against diabetes, obesity, cardiovascular disease, and metabolic syndrome. However, mother may not be able to breastfeed due to receiving special treatment. And unfortunately, most medications are not tested in nursing women. However, it is thought that medications that can cross the placental barrier can cross the blood-milk barrier as well. So for drug use in lactating women with kidney disease, this table shows the most commonly used drugs in women with different kidney disease. and its relation or its precautions to be used in women, in lactating women. So here, for diuretics, furosemide in general should be used with caution to avoid milk suppression. Instead, chlorosizide can be used as safer alternative. As for antihypertensives, calcium channel blockers as amlodipine and nifedipine can be safely used. Beta blockers as metoprolol, labetalol can be used as well. And an alternative to labetalol should be considered in women nursing a preterm infants. Methyl-dopa is better avoided in the postpartum period due to the risk of maternal depression. Methyl-dopa is one of the commonly used antihypertensive medications during pregnancy, but in terms of lactation, in terms of postpartum period, it should be avoided because of the risk of maternal depression. RAS blockers can be used as a captopril, enalapril, and so, and candesartan as well as acceptable. Hydralazine can be used. For women with diabetes, the use of antidiabetics. Insulin is the preferred option in women on dialysis, and with pre-dialysis advanced CKD. Oral hypoglycemics as glimepiride, glipizide, and glypiride are better avoided due to the risk of neonatal hypoglycemia. Metformin can be used, but with caution in preterm infants. So as for immunosuppressive, prednisone, CNI, cyclosporin and tacrolimus can be used. Azathioprine can be used at lower doses, and MMF is still contraindicated as it is contraindicated in pregnancy. Regarding phosphate binders and calcitriol, sevelamer calcium salt can be used as phosphate binders, but yet no available data regarding lanthanum ferric citrate. Calcitriol is acceptable, and there is no available data regarding cinacalcet. And however, the breast milk composition, it changes according to the different gestational age of the fetus. It has been found that breast milk intake after premature birth reduces the risk of hypertension and reduces blood pressure after 13 to 16 weeks from birth. 13 to 16 years from birth. So, although premature delivery changes the composition of human milk, breast milk is greatly beneficial on the long term. So again, for the first few hours after delivery, special care should be given to the baby. There is no need for special treatment. He's or she's have normal weight to 500 grams or more, with normal temperature, feeding well, suckling effectively, and no signs of danger. Because in terms of maternal kidney disease, it's expected that there is high incidence of preterm deliveries and small for gestational age, and both increase the risk of long-term kidney disease, and not only kidney disease, long-term cardiovascular risk as well. So according to this, it has been revealed that the majority of nephrons are formed in the third trimester and is completed between 32 and 37 weeks gestation and may continue postnatally in infants born preterm. So when an infant is born prematurely or before 37 weeks, expected that the total number of nephrons are less than that for a full-term baby. And once the final nephron endowment is achieved, no more nephrons are formed. This means that the reduced nephron endowment at birth is associated with reduction in total renal filtration surface area and therefore diminished renal functional capacity on the long term. So it is thought, and there is evidence supporting this theory, that those born prematurely or born small for gestational age have low nephron mass, and for this they are at risk for cascade of events that will increase the risk of chronic kidney disease on the long term. So it is not only maternal kidney disease, it's not only preterm delivery that triggered this cascade, but many factors. One of those is maternal kidney disease. In addition, an infant born to a mother with kidney disease is at increased risk for neonatal acute kidney injury due to a variety of causes. Some of these causes start in prenatal with impaired ureteric blood branching, and then with the preterm birth, reactive oxygen species, inflammation, sepsis, infection, and hypotension, and the neonatal ICU course, which may be increase the risk of exposure to nephrotoxin, sepsis, hypotension, and extracorporeal therapies, all of which increase the risk of neonatal acute kidney injury. which in turn may not recover and lead to subsequent risk of CKD or end-stage kidney disease on the long term. It has been revealed that 16% of infants who have neonatal AKI had an increased risk of repeated episodes. After the first few hours pass until the time of discharge, which greatly varies among different centers and countries, special care should be given to the mother regarding the treatment or any prophylaxis which is used, the nutritional counseling, the family planning counseling. So as for the maternal drug dose adjustment, as for antibiotics, it's wise to use non-nephrotoxic antibiotics or antibiotics which does not need dose adjustment. Any antibiotic with broad therapeutic index and an easy to perform monitoring of pharmacokinetics and dynamics should be selected. Empirical prescriptions should be avoided as a general rule. As for analgesics, the common topic in practice, acetaminophen remains the mainstay for pain control. Non-steroidal should be limited, should be avoided, should be limited to the lowest effective dose and the shortest duration. Opioids as fentanyl could be considered as first line for pain control in pre-dialysis CKD, and tapentadol does not need dose adjustment in mild to moderate renal impairment conditions. So opioids can be used in severe pain. Acetaminophen is a good alternative in milder cases, but non-steroidal are not advised. For immunosuppressive drugs, corticosteroid, conversion to intravenous hydrocortisone at the time of delivery should be initiated to avoid corticosteroid insufficiency prior to the physiological stresses of labor. Doubling of oral steroid for the first 24 to 72 hours in the event of an anticipated labor or delivery is recommended. Increasing the dose of oral steroid or even administration of intravenous methylprednisolone is deemed safe in the PPRM and not contraindicated in breastfeeding if it is needed. The use of other immunosuppressive azathioprine at 2 mg per kg per day remains safe to continue postpartum. CNI, a return to the pre-pregnancy dosing after delivery is recommended to avoid toxicity postpartum, considering the narrow therapeutic index of the drug. Bubarium is known for high risk of venous thromboembolism, so anticoagulation may be considered with low molecular weight heparin or unfractionated heparin corresponding to the renal impairment should be initiated prior dose of oral anticoagulant, especially in case of a confirmed venous thromboembolism episode or in patients with nephrotic syndrome and severe hypoalbuminemia. And as for the nutritional counseling, indeed, there is no specific data regarding women with kidney disease in the postpartum period and what nutrients should they receive. But we have general consensus regarding the daily protein requirement for women with CKD, either pre-dialysis or in dialysis and in transplant, and the daily energy requirement, which should be considered, taking into consideration that we have nutritional requirement for any healthy women, either breastfeeding or not breastfeeding. This involves the protein, calcium, vitamins, iodine, and so. And it's as it's seen here, the requirement for breastfeeding women exceeds the requirement for non-breastfeeding women. So for protein requirement, for instance, women needs around 67 gram per kg protein per day compared to 46 for non-breastfeeding. And so for other nutrients. This table shows the recommended daily intake of core food group, including vegetables, fruits, grains, and lean meats, milk products for women as well who are breastfeeding and not breastfeeding. The KDOQI suggests that an adult with CKD 1 to 4 prescribing increased fruit and vegetable intake may decrease body weight, decrease blood pressure, and decrease net acid production, and this should be considered. Supplementation of vitamins and mineral is advised in terms of iron supplementation, either alone or in combination with folic acid, may be provided for postpartum women for 6 to 12 weeks following childbirth to reduce the risk of anemia. This is as a general rule. And as for calcium, because an extra calcium demand is needed particularly if the woman is breastfeeding and the major source would be the womb, and because the lactating breast secretes PTH-related peptide into the systemic circulation, which immobilizes skeletal calcium stores, which lead to maternal decline of the bone mass by 10%. Calcium supplementation as well is required. So in adult with CKD5D, it's reasonable to consider supplementation with multivitamins, including all water-soluble vitamins, all the essential trace elements to prevent or treat micronutrient deficiencies. This may be considered to increase dialysate calcium to 1.5 millimole per liter to provide a positive calcium balance of around 300 milligram per session for women on dialysis. One important point before discharge is counseling regarding family planning. This should be advised as early as possible because pregnancy can occur as early as 4 weeks postpartum, and unplanned pregnancy is almost a big problem. So what contraceptive options may be safe in terms of women with kidney disease? In the general rule, estrogen-free hormonal contraception is advised. This may include the intrauterine device, progesterone-only pills, subdermal implant, and injectables. But we should pay attention to the contraindications, either the absolute or relative contraindication. So as we can see here, the subdermal implant is absolutely contraindicated in thromboembolic disease. As well, the injectable is contraindicated in women with coagulation disorders. All the devices, and the intrauterine device, POB, subdermal implant, and injectables are relatively contraindicated in women with SLE, with antiphospholipid antibodies, hypertension, maybe diabetes, so should be used under monitoring. The estrogen-containing hormonal contraception is not recommended in women with chronic kidney disease, is absolutely contraindicated in SLE, antiphospholipid, those with coagulation disorders, and so. It may be rather safe in women with recovering pregnancy-related acute kidney injury, may be used in other patients with early disease. Other contraceptive options, I mean the barrier methods, there is no absolute contraindication for their use, but there is many concern regarding their efficacy in prevention of conception. So the clinical practice guidelines for contraception in kidney disease recommend that progestin-based preparations for safe and effective contraception in women with CKD. When the woman is ready for discharge, it's a time to advise her about a second contact. The patient should have a second contact with her physician at least 40 hours to 72 hours after discharge. Should be advised about the third contact, should be advised about when should she present to the hospital or should contact her physician when there are alarming signs. If there is fever, if there is lower urinary tract infection, whenever there is signs of perineal infection or pain, uncontrolled hypertension, urinary incontinence, severe anemia, postpartum pause, when there is moderate anemia, or if treated in hospital for any complication. The woman should receive advice when should she return to her physician. So the postpart described the early postpartum period, the early few hours in the postpartum period. And now I'm presenting the short to moderate term, which starts from day 2 postpartum, or maybe after the time of discharge, till 6 months postpartum. This should include maternal follow-up and neonatal follow-up. And neonatal follow-up should include observation of the developmental milestones and the kidney function for those at risk. And among those at risk, those who were born prematurely or as small for gestational age, and those who developed neonatal acute kidney injury in the early postpartum period. So particular care should be given to those who required neonatal ICU admission. As for the maternal follow-up, while we're continuing on the early measures with monitoring of the postpartum bleeding and wound care with drug dose adjustments, family planning, nutritional counseling, and so, kidney function should be paid special and utmost care with monitoring of the blood pressure, urinary protein, and serum creatinine. Because among the heterogeneous population, the risk of drop of EGFR, the worsening of kidney function is expected in the early postpartum period. Other conditions may occur during this period with postpartum preeclampsia and TME flares. They should be suspected with new onset significant hypertension or accelerations in the pre-existing hypertension more than 160 over 110, or in the presence of severe headache, visual disturbance, or other focal neurological signs. In this context, postpartum preeclampsia, postpartum thrombotic microangiopathies should be suspected. It has been revealed that 23% of women with non-CKD demonstrate first decline in kidney function between delivery and 6 weeks postpartum. However, there is no clear guidance on when EGFR becomes valid post-delivery. As we know, EGFR is not reliable during a pregnancy, and we cannot rely on to determine the CKD stage or to assess the kidney function during a pregnancy. As well, there is yet no clear guidance on when EGFR becomes valid post-delivery, but it has been revealed that a significant proportion of women experience first decline in kidney function postpartum. So they should be carefully monitored as regards the kidney function. Preeclampsia is suspected in the postpartum period because there is a vicious circle between preeclampsia and chronic kidney disease. CKD can induce placental dysfunction and preeclampsia, so preeclampsia may be a precious opportunity to screen for CKD. And on the other hand, preeclampsia can induce permanent CKD due to podocyte loss and AKI, so postpartum follow-up is crucial. Postpartum follow-up till normalization of the blood pressure, urinary protein, and serum creatinine. And because pregnancy-related AKI may be a common complication, particularly in women with pre-existing chronic kidney disease or pre-existing kidney disease, time is a great concern because delayed recovery more than 3 months is indicative of chronic kidney disease, which implies a future risk of chronic kidney disease and the cardiovascular disease as well. As a part of the short to moderate term maternal follow-up, special care should be emphasized with a weight reduction. Postpartum weight gain almost occurs due to irregular, inadequate sleep in the postpartum period, disruptions to meal routines, the physical inactivity, and lack of access to nutritious food, all of which can lead to postpartum weight gain. And psychological considerations should be considered in this context, as we will show soon. So it has been revealed that women who retain weight postpartum are more likely to have higher body weights 15 years later, and supporting women to return to pre-pregnancy weight by 6 months postpartum and no later than 1 year, no later than 12 months is associated with more favorable outcomes. Exclusive breastfeeding to 6 months postpartum may help weight reduction, in terms of weight reduction, and all postpartum women without contraindication should be advised to undertake regular physical activity and incorporate a variety of physical and muscle strengthening activities. And because gestational diabetes can be or play a major role in this setting, up to half of pregnant women with gestational diabetes will develop pre-diabetes or type 2 diabetes postpartum. Effective lifestyle interventions should be adopted to prevent type 2 diabetes, improving lactation, weight reduction, exercise, maybe pharmacotherapy. It's important to check with glucose tolerance testing with 75-gram oral glucose tolerance test at 4 to 12 weeks postpartum for resolution of gestational diabetes. Postpartum depression is an important issue in the general population, and further important in terms of women with chronic kidney disease receiving immune suppression. And so postpartum depression is thought to occur due to disruptions in reproductive lactogenic hormones, due to stress, genetic backgrounds, neuroinflammation, and so screening for postpartum depression and anxiety using a validated simple instrument such as the Edinburgh Postnatal Depression Scale has been found to improve the early identification and referral for treatment with antidepressant and psychotherapies. Psychosocial or psychological interventions during the antenatal and postnatal period are recommended to prevent postpartum depression and anxiety. Almost a forgotten topic. When the women reaches 6 months postpartum, still we need to follow the mother and need to follow the baby or the infant. In more than 6 months postpartum, which reflects the long-term follow-up, still we need to follow the mother, assess the cardiovascular risk, because women with kidney disease in the postpartum period are more prone to cardiovascular complication as well, be seen soon. And for the child, assessment of cardiovascular risk, assessment of chronic kidney disease on the first instance with serum creatinine, urinary protein, and blood pressure may be required. Kidney disease risk is thought to begin in fetal life and is impacted every day with life challenges or life events. So during the fetal life, the maternal comorbidities, the maternal kidney disease, diabetes, obesity, and when born prematurely with low birth weight, preterm, small for gestational age, life challenges with sedentary life, pollution, infections, and so throughout the life course increases the risk of kidney disease. And it has been revealed that the infants who were born as low birth weight have 1.72 higher risk. Small for gestational age have 1.79, and those for preterm birth 1.48 higher risk of chronic kidney disease on the long term, and for other kidney disease as well. And this graph shows a graded risk that being born very prematurely, very or extremely preterm, is associated with more risk for chronic kidney disease compared to those who born early term or full term. Preterm and small for gestational age increases the risk of CKD by 3-fold. Childhood obesity after premature birth is also revealed to accelerate progression of chronic kidney disease. Pre- and postnatal nutrition impact GFR at the age of 7. So another factor that contributes to chronic kidney disease on the long term in those infants. So follow-up and monitoring is recommended. Simple approaches can be adopted with monitoring of the blood pressure, at least the annual blood pressure monitoring, a prevention with review of the neonatal history, avoidance of nephrotoxicity, advisance of healthy lifestyle with low salt, advising physical activity promotion, avoidance of rapid weight gain in infancy and the childhood, monitoring of the kidney function if the child or the baby was at risk during the early postpartum period, and the prompt referral to nephrologist in case of any abnormalities in kidney function, or in case of hypertension, or in case of abnormal ultrasound. And as for the mother, it's important to follow the cardiovascular risk and highlight that the long-term risk of the preterm birth are not only renal. This prematurely born child is at risk for other metabolic and cardiovascular complications, maybe the risk of diabetes, maybe hypertension, and so. It is interesting to find that the risk of gestational diabetes or hypertension in a mother who had been a preterm at time of delivery is higher. So the babies, the female babies or the girls who were born prematurely, they are at higher risk or greater risk of gestational diabetes and gestational hypertension, and the risk is proportionate to the gestational age. And the risk of preterm delivery in a mother who had been preterm is also greater than those who were born at or full term. Unfortunately, we don't have such data. Having or defining these risk factors represents a good or an excellent opportunity to screen the general population, to screen those who were small for gestational age or born prematurely or were low birth weight at time of birth for CKD, because they have a higher risk of CKD and they may be carrying undiagnosed CKD. So screening is crucial in this instance, but the challenge is that we don't have health records. Around 50% of persons in Africa have no birth weight measures. We don't have registers for the birth weight. We don't have the registers for the early neonatal complications, which may warrant consideration of screening for those population. So it seems that multiple hits, multiple strikes with contribution of the congenital kidney disease or inherited disorders, contribution of the low nephron number, acquired kidney disease, and contribution of the life challenges, all these can lead to progression or can lead to worsening or can lead to a number of risks as regard the kidney and the cardiovascular risk on the long term. The WHO proposes a model for intervention to support healthy care practices with strengthening postpartum contraception, infant growth and development, maternal and newborn nutrition and breastfeeding. And so it's important to highlight that new definitions are being used to improve the care with definitions for those born too soon or born too small or low birth weight, being representing more than half of neonatal deaths and having increased risk for a multitude of adverse health conditions. And about to finalize my presentation is that we have many gaps in this area, which we hope to bridge with future studies and provide more strengthened evidence in this context. And thank you.
Thank you, Dr. Rasha, for this highly elegant and comprehensive lecture that included, I think, all of the aspects and including many and many questions, the answers of many and many questions. I really was expecting you to answer these questions, and I think such lecture and is to be used as a reference. And for me, I really wish to have a PDF copy to be with me in hand to use when I face such women with kidney disease following after their delivery, regarding their drug doses, every antihypertensives, immunosuppressives, antidiabetics, and almost covered almost all the complications that the lady can be exposed during her pregnancy, how to deal with postpartum, and even the baby. You didn't ignore the baby, how to deal with the baby itself, what are the complications expected to occur for this baby, and how to take care, and even extended your care up to 6 months postpartum, including the possible risks, including cardiovascular risks, for example. We have many questions on the chat, and I can see many professors commenting, wanting to comment. But excuse me, the first to ask you a question, you said that, and it's already on the chat also, this question from Dr. Abdelhamid about steroid use. You said that immediate, you are to shift to IV hydrocortisone in the immediate pre-delivery area, and said that oral corticosteroids up to 2 days before labor. So what is the date or the time interval you shift to recommend to shift to IV steroids? Is it time of delivery, at the instant of delivery, or the day of delivery, or what's that? And the question was about the use of IV dexamethasone instead of IV hydrocortisone.
Thank you, Dr. Yasser. As for steroid, the mode of delivery because it differs whether this woman is going to deliver by vaginal route or by cesarean section. And in practice, most all women, even the healthy women, are going to deliver by cesarean section. So if the woman is gonna deliver by Yeah, the vaginal route is expected as stressful labor or obstructed or complicated labor. In this context, it's advised to shift from oral to intravenous steroid. Hydrocortisone is the one advised in literature. Yet we use dexamethasone in those women as it is known to cross the placenta for enhancing lung maturity when preterm labor is expected. This is the thing we use dexamethasone in. We almost shift away. We admit the patient for a preparation for the delivery around 24 hours before the time of delivery. But as I just said, most women deliver by cesarean section indeed, and may not have to follow this routine advice.
Okay, thank you. Professor Ayman Rifai, please.
Thank you very much, Dr. Rasha. I really enjoyed your lecture and the presentation. Actually, it was well designed, and the slides were clear, the language. I enjoyed the lecture really, and I totally agree with Professor Yasser that you addressed or you presented a huge information which was highlighted in your talk, not only the postpartum care. So I suggest that you could retitle this presentation to have a broad title to involve pregnancy, conception, contraception, delivery, etc. So thank you very much. This is a reference presentation, as Professor Yasser said. I have two questions, and actually there are two challenges that I think we always face in our practice, and we need answer with figures or numbers. The first challenge is when to allow a patient with CKD to get pregnant in view or regards to the serum creatinine, the GFR, the proteinuria, hypertension, etc. And the other challenge is when to terminate or to decide to terminate a pregnancy with deterioration of renal function and increasing proteinuria, uncontrolled hypertension. Could you please give us figures for both challenges? Thank you very much.
Thank you, Professor Ayman. So I'll go for the first question, when to allow CKD to get pregnant. Indeed, it's a difficult question to answer because motherhood is a human right. And sometimes we meet the women who's striving or desperately wishing to get pregnant despite many complications or being unstable, and she's eager to lose her kidney function, to lose the kidney as a whole, but have a baby. So we try to have a stable kidney function before we allow pregnancy. So for those who have glomerular disorders, for instance, it's advised that they should be in remission for 6 months to 1 year before they go to pregnancy, for those women who have active glomerular disease or glomerular disorders. For those with CKD, they can get pregnant, but dialysis may be needed in some cases who have advanced stages of CKD or have high serum creatinine in terms of improving the environment for the fetal growth. So they may start, however, they may progress. They are counseled and they are counseled regarding the complications and the outcomes and everything, but the woman has to decide and has the freedom to take the decision to get pregnant or not. So she can start during pregnancy and then, during CKD, and then can start dialysis. There is some debate whether to postpone after transplantation or not. This debate relies on the fact that fertility may improve after transplantation, outcomes may improve after transplantation, but in some cases where there is risk of recurrence, or there is risk of rejection, or there is risk of complications in the post-transplant, it may be advised to try pregnancy in try pregnancy before going to transplantation. There is debate around this point. For the second point, when to terminate. Generally speaking, in women with CKD, women with stable glomerular disorders, we should be pushing as much as we can till a safe age for termination. The safe age of termination determines according to the available neonatal care. So here we almost find difficulty to have a successful outcome before 32 to 34 weeks gestation. Those infants born before 32 weeks gestation, considering the national circumstances, is difficult to yield a successful outcome. So we're trying to push as much as we can to 32 or 34 and then prepare for termination of pregnancy if the women started to develop any instabilities. Before this, before 32 weeks, it's a matter of cost benefit, because if there is a preeclampsia, for example, and there is severe preeclampsia with complications and a multi-organ affection, the mother's life is the priority to save. So we may need to terminate pregnancy. However, it is not almost going to be successful pregnancy. On the other hand, if we have a woman which need termination, but yet can be maintained with modifying the immune suppression, with increasing the doses, with increasing the dose dialysis, we can provide some support, so we can continue till the least possible gestational age to terminate. So it seems this individualized approach and to difficult questions as regard to both when to allow and when to terminate.
Thank you, Rasha. Question on the chat. Thank you, Professor Ayman. Question about the use of biological agents, rituximab, such as rituximab, for example, in pregnancy and postpartum period.
I have no personal experience with the use of rituximab in pregnancy, but in terms of literature, it is not a first line in pregnancy management. It is considered a rescue therapy. It's off-label, but it is tried in many centers in Europe and USA, and they have experience that may be safe and effective, particularly in women with membranous nephropathy, for example. So some have tried rituximab and some advocate its use, but yet there is no consensus regarding its use in pregnancy, at least a rescue therapy in case of failure of first-line therapies.
Okay. Thank you, Professor
Rasha, could you allow me for a small comment?
تفضل دكتور أيمن.
تفضل دكتور أيمن.
Do you agree, Dr. Rasha, that we should share the patient, husband, and even some members of the family in both decisions, either to get pregnant or to terminate? I think this is a must. What do you think?
Sure, Dr. Ayman, sure, because many of the circumstances, the pressures comes from the family, comes from the husband. So these social pressures may help support the patient when they are are considered in the decision.
Okay, thank you.
Thank you, Professor Hisham Al-Sayed. Professor Hisham. Professor Kamal Okasha, please. Unmute yourself.
I am muted, yes. دلوقتي كده unmuted خلاص.
اتفضل دكتور هشام.
Thank you very much, Dr. Rasha Samir. I enjoyed. I just lost the connection for a while for the internet, but I may pass these positions, but I am asking again with the Professor Yasser that we need your PDF is just a guideline. First things, I think we have to integrate your documents here into the next guidelines update for the hemodialysis. I described that shortly in the previous one, 2019, as we need hemodialysis, augmented type of hemodialysis during pregnancy. I have two questions here. I don't remember that I heard that in your talk, but you can answer again if you please. First, in some literature, they say that dialysis should begin if blood urea is above 50 milligram per deciliter. And I am against this way. And in other literature saying that you can start hemodialysis if uncontrolled, as usual, blood pressure, volume, status, and metabolic profile. My second question, we know that exactly that the pregnancy outcome is linearly dependent on the hours of dialysis per week. So we wrote in our guideline, it's a minimum of 20 hours per week. And in some literature saying that 36 hours per week, which is, I think it's a huge dose of dialysis. So if you can just highlight both conditions, this is my first part on dialysis. My second part, what about renal biopsy during pregnancy? Do you have any consensus about that? Many of nephrologists are afraid to do biopsy unless it is life-saving during pregnancy, and how is safe during trimesters? And thank you very much again.
Thank you, Dr. Hisham. Professor Hisham, so for the timing on dialysis, to the best of my knowledge, there is no consensus on at what level of serum creatinine urea should we start. There are some maybe suggestions to start at serum creatinine 3 or more, or serum urea of 50 or more. But indeed, other points should be considered as the clinical condition and the control of the complications and so. However, we had some experiences in our practice who refused to do dialysis during pregnancy and continued with creatinine 5 and more without dialysis till the end, and the outcomes were fortunately successful. So
I agree on that. I agree on that. That we shouldn't start dialysis unless it's life-threatening or required for that. Unless it's some literature describing that a significant blood urea above 50, which is far away from the clinical life that blood urea 50, you can manage your pregnancy till the end by these levels.
Do you mean blood urea, PON, Hisham?
Yeah, blood urea, blood urea,
Oh.
and even they describe that as a adequacy of dialysis during pregnancy is to have a pre-dialysis blood urea below 50. That's too little values. So it is not my opinion, it's written, but I am against this opinion.
Yeah. So for the dialysis dose, there is a good body of evidence toward the proportionate relation between the dose of dialysis and the successful outcomes. Yeah. So the Canadian model adopts the 36 hours, but yet it's more, it may be difficult to adopt in terms of maybe social, maybe financial constraints. So at least 20 hours, as you just said, Dr. Hisham, is the least allowed.
We wrote that in our guidelines, at least 20 hours per week.
Yeah.
Okay, thank you very much. The second question about renal biopsy. What do you think about? Is it completely safe or carry risk of a biopsy doing for a pregnant woman?
There is a big debate on kidney biopsy this month in literature.
Yeah.
To do or not to do kidney biopsy. Yeah.
Yes. Yes.
So indeed, kidney biopsy may be needed during pregnancy if it will guide the decision, the management, the decision or treatment. If it's expected that it will yield a disease that may need special treatment, for example, a certain glomerular disorder or certain conditions that may need immune suppression or plasma exchange and so. So it may be a priority during pregnancy if there is worsening kidney function before
life-threatening disease for sure.
Yeah, worsening kidney function before 32 weeks if there is nephrotic syndrome. And so these are conditions to consider kidney biopsy during pregnancy. And the risk is not that different from the general population. The current evidence shows the risk of pregnancy, the risk of kidney biopsy during pregnancy seems comparable to that of the general population, not that different. But it's still advised the earlier is the better. To do biopsy before 20 weeks, this is the most optimistic protocol, and to do before the most pessimistic, before 30 weeks is still the most optimistic one. So some advocate kidney biopsy to be done before 20 weeks gestation, and others still do biopsy before 30 weeks gestation. We have maybe an experience of around the 20 cases of kidney biopsy during pregnancy, almost around the 20 to 22 weeks gestation. We had complication twice. One developed hematuria and one developed hematoma, but both were just mild cases and passed.
And comparable to normal population to have some hematoma or hematuria during the biopsy.
Yeah,
it's not specific for pregnancy.
In terms of the current literature, they are comparable to the general population, the complications. In terms of old or historic data, when biopsy was first done during pregnancy, I mean in the early 15s, in 1954, when biopsy was first done, they used to do biopsy at the 39th week gestation, just a few days before delivery. And despite that, they had almost no complications.
Okay, thank you, Dr.
Thank you very much.
Thank you, Professor Hisham. This gives me a question that the need of biopsy in case you need to adjust for treatment. So I can imagine, I think, and all can imagine that this emergency case would be some sort of rapidly progressive GN. Let me ask you about your experience. Did you have an experience with such a case of rapidly progressive GN treated during pregnancy and passed a smooth course till delivery, proper management and delivery of a full-term alive baby?
Yeah, but I'm not sure about the number of cases with such a presentation. What I remember that most cases may warrant early termination as soon as possible.
Yes, this is my
question. Few cases respond to the immune suppression and go smoothly to continue the pregnancy. Few cases. Yes. I'm not sure about the numbers, but yeah.
Yes, so still we are to keep hope. Professor Kamal Okasha, please.
Thank you very much. Thank you very much. You just take us an overview, navigation throughout pregnancy. Since start thinking about my question actually, which may be overlooked in many literatures about the polycystic kidney disease. Hello?
الصوت مش واضح، الصوت مش واضح دكتور كمال، بس you wrote on the chat.
Yeah,
Professor Kamal, polycystic kidney disease and the TPE.
And what are the pitfalls, or the complications of polycystic kidney disease on pregnancy and the effect? Do we have to care for having a baby? What time? Please, Professor Rasha.
Let me explain the Professor Kamal question. I think the voice was somewhat interrupted.
I hear the question about
polycystic kidney disease, and the second question was about the use of therapeutic plasma exchange.
Both, please. I am asking for both therapeutic plasma exchange in pregnancy and the polycystic kidney disease actually, and the impact on pregnancy and vice versa.
Okay. Please, Professor Raj.
The management of polycystic kidney disease in terms of pregnancy does not much differ compared to the non-pregnant population, because we're managing conservatively to control the blood pressure, the hypertension, and the other complications. So if the patient has a good control of blood pressure, has an early CKD stage rather than late CKD stage, has almost mildly elevated serum creatinine, they almost successfully pass to a good outcome. But those who have advanced CKD with polycystic kidney disease and control the blood pressure and so may have worse outcomes. As for therapeutic plasma exchange in pregnancy, indeed we have we need to use this therapeutic plasma exchange in terms of TMAs on the first instance, which almost occur in the peripartum period, late pregnancy and the early postpartum period. For women who are presenting with atypical HUS, maybe thrombotic thrombocytopenic purpura, and as we know, we start the plasma exchange till we exclude the diagnosis of a TTP. I mean atypical. If the diagnosis of typical HUS is confirmed, there is no need to continue on plasma exchange, but it's time to start the drug which is not available here, which is eculizumab. But there are recommendations from the Society of Plasma Therapeutic Plasma Apheresis, if I'm remembering its name correctly, to apply or to start prophylactic plasma exchange for women with congenital TTP since the time of conception until delivery. So women who have a congenital TTP diagnosed in previous pregnancy should undergo prophylactic plasma exchange, considering the critical condition throughout pregnancy, from the time of conception and maybe earlier to conception until the time of delivery, like the dialysis in a routine weekly management. The other indication is with the occurrence of TMAs in the peripartum period or maybe in the postpartum period, till the diagnosis of TTP is excluded and the atypical HUS is made by exclusion. It's time to stop therapeutic plasma exchange.
Thank you. And regarding the technique of plasma exchange, I think we are to keep the hemodynamics properly, maintaining placental circulation and avoiding so much negative balance regarding the procedure itself and replacement during the session. Please, Professor Samir Al-Khashab.
I go for plasma exchange. How many sessions and how much volume?
So it depends on the indication. If you mean Professor Kamal, the women with TMAs or supposed to have TMAs, we start 3 to 5 plasma exchange and monitor the response with the serum creatinine and the hemoglobin and the platelet count, and accordingly we decide to continue or to withhold the plasma exchange sessions. Unfortunately, we don't have the Adams S13, or we don't have the complement factor H and I, and so to make a diagnosis based on solid evidence. But we try to make it just empiric, depending on the clinical presentation or the clinical profile of the patient.
Thank you very much. Thank you. Thank you, Dr.
Thank you. Welcome, Professor Hasham. Professor Samir Al-Khashab, please.
Thank you, Dr. Yasser. Thank you, Dr. Rasha, for this elegant lecture. I'm very much interested in that field since I was a resident, actually, since I was a student. I have one comment for you and one question. Would you agree with me that pregnancy in kidney disease, whether chronic kidney disease, transplant, or dialysis, should be planned? And this is very important because when a patient comes up suddenly with pregnancy, this is very difficult or more difficult, let's say, to manage. So any woman with kidney disease should be instructed that her pregnancy should be planned at least 6 months before, correcting anemia in chronic kidney disease, stopping immunosuppression, or replacing Silcept or MMF with azathioprine. Would you agree with me with that, or do you have another opinion?
Totally agree. And for this, particularly, we established the Zeri Mansoura Obstetric Nephrology Clinic to see patients before they got pregnant and to imply pre-pregnancy counseling and monitor carefully throughout pregnancy for the sake of the maternal and fetal outcomes. So totally agree, Professor Sayer.
The other thing, thank you, Dr. Rasha. And the other thing is, do you have any clue or any guide of how to monitor the intradialytic weight gain, or let's say the dry weight of pregnant women during dialysis? Because this is a mistake, or let's say a pitfall that many nephrologists fall in, that they calculate the dry weight according to the or as if the patient is not pregnant, and pregnant women do gain weight. So if you do lots of ultrafiltration, this is hazardous not only to the mother but also to the baby. So is there any guideline, or is it just a trial and error, or how do you monitor that?
The guideline is on the way. On the way. I know that there is no clear, or there is no specific guideline for determination of the volume changes during pregnancy in women with kidney disease. But the ADIC group is now preparing a guideline, which is considered to be released soon, within few, maybe 2 or 3 months. And I hope it will be helpful, inshallah.
The last thing is about immunosuppression in our lactation in transplant patients. I have lots of transplant patients who got pregnant, and I read lots of articles about that. There's no problem in giving, in lactating, but there's a problem in the mother getting mastitis. And when a mother with a transplant gets mastitis, this is really a bad infection. So in your practice, not according to the guidelines or the scientific arguments, or in your practice, do you recommend a transplant woman to continue breastfeeding with the risk of getting mastitis?
Indeed, I may have seen a few cases with transplantation in the postpartum period. I have never been confronted with a case with mastitis in such a case. Maybe our professors who have greater experience in transplantation may have an answer for this question.
Thank you, Professor Sahir. Professor Ayman, please.
Thank you. And I think yes, let me say that the issue of renal biopsy during pregnancy is one of the debatable and controversies that will be addressed in the upcoming EST Congress. This will be between Professor Osama al-Minshawi and Professor Samir Salli. The one will be the cons, and the other will be the pro, discussing all the aspects and of the performing kidney biopsy in pregnancy. Regarding the question of Professor Clara Wakasha about the polycystic kidney disease, I think that he means, or his concern, if I understood, about the huge kidneys and the challenge of having pregnancy in the presence of huge kidneys occupying the abdominal cavity. I understood that it was not about the hypertension, the degree of CKD, and so on. Is it right, Professor Kamal, or what do you think, Professor Rasha, about having a lady with huge kidneys filling the abdomen and the challenge of pregnancy in this situation?
Dr. Ayman, agree theoretically. I have never been confronted with such a case, but theoretically, having a huge kidney may prevent the normal growth of the fetus, or normal pregnancy, and may warrant surgical interference before planning to pregnancy. This is what's written in the literature, but I have not been confronted with such a case in my practice.
We can measure, Professor Ayman, of a case having a huge intra-abdominal mass and getting pregnancy, and in such case I can remember that the baby was low birth weight, and she had a preterm labor, not premature, preterm labor, and low birth weight baby at about 36 or 37 weeks gestation. We can measure the case regarding this polycystic kidney disease. Thank you, Professor Ayman, and thank you, Professor Rasha, for your response. I have a question. You said that we can we are to give iron and calcium supplementation. Of course, calcium supplementation are well known for ladies postpartum. But in patients with women with kidney disease, CKD, non-chronic kidney disease, should we give, as you said, absolutely in all women, or should we stick to the guidelines of CKD, non-CKD for treating anemia, for treating bone disease, for example, after delivery, Professor Rasha?
Calcium supplementation should be considered in terms of expected bone loss during lactation in a woman with CKD. But
Okay.
this should be within the or considering the CKD MPD lines of or treatment or parameters of treatment. So if the
Yes.
patient has hypoparathyroidism or so, they may change the decision of treatment or the prescription.
And the iron?
Iron is considered for the general population, for all women, for prevention of anemia, but as well, the case will the treatment will be individualized according to the presentation or according to the clinical profile of the patient who has maybe iron overload, maybe high serum ferritin, anti-SAT, and so. Yeah.
Yes. So we should remember or go to our guidelines, non-guidelines for CKD. In addition, you should consider that we are to give these supplements, and they are essential in this stage. But again, going to our the known rules of our non-guidelines of CKD, MPD, and anemia management in chronic kidney disease patients. That's it. A question, and really from. He is stressing on a point you discussed with Professor Hisham Sayed, Dr. Ahmed, that dialysis is not at the lower level of blood urea. So I think the usual is to understand is that we are to dialyze upon indication. If we are not to stick to a single or to a known level for blood urea and blood serum creatinine, we are to go to indication. So what about if you go to dialysis on indication? What about the growth of the baby or the proper maturity of the baby? What is your comment about this? Will we get the proper maturity time if we stick to dialysis on indication?
Sorry, Dr. Yasser, I had some interruption.
Yes, you discussed with Professor Hisham Sayed that you are not to stick to a lower blood urea to initiate dialysis in women with
To start the dialysis, yeah.
Yes, you are not to stick to lower blood urea, and you agreed with him. So I think the next step come in mind that we are to dialyze upon indication.
Yeah.
Or higher blood urea and or higher laboratory values.
It's rather the clinical profile, maybe in view of absence of consensus. It may be the clinical profile rather than the absolute lab values.
So
here I don't mean the urgent indications of dialysis, but I mean the earlier indications when we have a patient with some symptoms. We have patient with uncontrolled volume, metabolic disturbances, electrolyte, and so.
If we will wait to the appearance of these clinical findings, even yearly, what about the proper growth of the baby? Is there any studies or any comparison regarding this?
Some studies available regarding early start of dialysis or start of dialysis according to the lab values, showing maybe relatively good outcomes. But yet there is no consensus regarding this point. But I don't mean we wait till the patient develops the complications. I mean manage according to the clinical presentation of the patient or according to the clinical indication. It is not only the lab value. Some patients actually refuse to do dialysis. Some patients we have experienced refused to do dialysis and continued with serum creatinine around 5 and 6 and so, and the outcomes were not bad. They have successful outcomes, or they have at least living birth babies. But I cannot recommend this. Just my my observation or my experience with few cases. But In terms of the lab values, there is a great debate about this.
Okay, thank you. Last comment from Professor Hisham Said. Again, I think he wants to comment about this. He is commenting on the chat that we, instead of biopsy, we can do anti-Plar A2, and I think his comment were about this point, about initiation of dialysis.
Thank you very much, Professor Yasser. Again, considering starting dialysis, I am afraid as well that dialysis is not a good thing to do in pregnancy as well. You know that stress factors, hypovolemia, shock, intradiabetic complications, oxidative stress. So it is a devil to start the dialysis in non-clinical indications. And I fully agree that with Rasha that we have to be very adherent to the clinical situation rather than the levels, because dialysis can deteriorate the residual kidney function very fast. My comment, if that's my experiences in some pregnant ladies, that I do Plar, anti-Plar. So most of cases was positive for anti-Plar, and I didn't require the biopsy. As Professor Ayman said, that it's a constant process, and you will keep that in discussion in the Congress, inshallah.
Inshallah. Thank you, Professor Hisham. Professor Said Khalid.
Thank you, Professor Yasser. Thank you, Professor Rasha, for this elegant presentation. Just I have a comment and this three very short questions. The first comment regarding the question of Professor Sahir regarding the dry body weight in pregnancy on dialysis, in pregnant lady on dialysis. There is no consensus about this, but we should, our aim should be to avoid the hypotension because of the placental perfusion. I mean, to keep the patient hemodynamically stable as much as we can. And this should be individualized. But we should know that in the first trimester, the patient increased from 1 to 1.5 kilogram. And then from the second and third trimester, it increased from 300 to 500 milligram per week. So we should consider this in the ultrafiltration. My quick questions to Professor Rasha. If you don't mind, could you please tell us in a very short statement regarding these 3 points? Number one, the incidence and the management of the cortical necrosis, peripartum cortical necrosis, because actually from my, I can't say experience, but it is, we underestimate this complication in our patients actually, especially in the presence of prolonged hypotension postpartum due to postpartum hemorrhage, or in the abruptio placenta leading to antepartum hemorrhage. The second issue is regarding the neonatal lupus syndrome. In the practice, did you face any cases like this, and what the protocol should be done in such cases? And last question is regarding the AKI in this ovarian hyperstimulation syndrome. Thank you.
Thank you, Dr. Khamis, Dr. Said. Indeed, the 3 points are lengthy questions. Yeah. So as for the first one, the incidence of cortical necrosis. In our experience, almost half of the cases presented to us with pregnancy-related AKI are due to postpartum hemorrhage. More than half are due to preeclampsia, but around or less than half are due to postpartum hemorrhage. And if I will remember the numbers, 37.5% of those women did not recover their kidney function after presentation. And kidney biopsy was considered only in few cases in the postpartum period in women who do not recover their kidney function. And a cortical necrosis was described, I think, in less than 5 cases. Let us say who have non-recovery of their kidney function, persistently high serum creatinine, being dialysis dependent and discharged as end stage. So unfortunately, we see these cases late. These cases who have developed severe hemorrhage are referred to us in a late presentation while they have actually experienced severe hemorrhage in an obstetric unit or an obstetric outpatient clinic or something like that, and then becomes referred anuric or oliguric and so. In such discussion with the ISN group, they almost never seen such cases in the current time. They were amazed that we still have cases that remain totally anuric after delivery because of severe hemorrhage, and so it seems unfortunately that it's our current practice. We see these cases, yeah. For the neonatal lupus, only one case. We almost do anti-law and antibody testing in the first trimester of pregnancy. We have seen one case with congenital heart block during pregnancy. And see two cases. It is not cannot be defined as neonatal lupus syndrome, but we have seen two cases that presented with neonatal fetal congenital anomalies because those women were maintained on MMF while they had unplanned pregnancy. So one of them discovered her pregnancy at 21-week gestation, and they presented with a number of congenital anomalies. Some of those were not previously reported, so we published this case. Many facial and limb anomalies, and another case were also maintained on MMF, but only one case with congenital heart block.
Thank you.
And third, with this AKI in ovarian hyperstimulation?
In terms of AKI and ovarian hyperstimulation, we almost see these cases, women with infertility treated with ovulation induction. And because we're talking to about CKD this day, يعني, I think it's a good opportunity to recommend against the use of ovulation induction in women with CKD. Instead, in vitro fertilization, IVF, or other techniques like egg-sealed intracytoplasmic sperm injection can be rather used in women with kidney disease or women with CKD, and avoid the use of ovulation induction. It's a relatively reported complication. I have no data about the incidence in Egypt of AKI complicating ovarian hyperstimulation syndrome, but seen many cases throughout the past years. Almost are self-limited and fully recover on supportive measures. I saw or just have read an interesting case which developed huge bilateral ovarian enlargement, compressed the post-ureters on both sides, and led to post-renal AKI in a case of ovulation induction. Was a case published in literature, not my case.
Yes, thank you, Professor Rasha. Thank you.
Thank you, Professor Saeed. Thank you, Professor Rasha. I received many thanks on the chat. Professor Manal Adib, Dr. Ahmed Mazen, and many audiences are thanking you on the chat for this brilliant talk. And thank you for all professors for this heavy and fruitful discussion. No more discussions and no more comments. And I think we are to close this very interesting session. Thank you, Professor Rasha, for your very comprehensive, excellent talk. And I wish to meet you again in many sessions about women disease in nephrology. Thank you all professors who shared us, Professor Ayman Rifai, Professor Hisham Sayyid, Professor Kamal Okasha, Professor Saeed Khamis, Professor Sair Al-Khashab. Thank you, Dr. Mu'tasim Sayyid, for being the coordinator of this session. Excuse me to close this session and meet you next Wednesday, inshallah, in our time, 9 p.m. Cairo time. Thank you. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام.
وعليكم السلام. شكرا جزيلا.
عليكم السلام.